Hi guys, welcome to video 3 in this third part of the introduction to the cardiovascular system, focusing on the heart. Again, before I get started with this, I do want to emphasize, I just want to keep doing it because I know medical students and I know you guys are going to want to study everything, and there's a lot to learn already for this first case in the block, okay? I don't want you to panic and come to me and be really upset because you don't understand the details of everything I talked about, particularly in this third lesson in the series. Please don't panic, okay? The truth of the matter is, I can't stop Dr. Broderick from talking about positive inotropic drugs completely, and I certainly can't stop the clinician educators from doing it. And the purpose of a lot of this, just for this introductory series of lessons, is just to make sure that if a clinician educator starts talking about the autonomic nervous system or starts talking about the heart rate going up and down, I want you guys to have a general idea of what they're talking about. You don't have to know the details, but I don't want you to be completely out in space with it. I just want you to have been exposed to it. And it also helps me because if I know you've been exposed to stuff like this, then I can bring it back before I've had a chance to go through the details, knowing that you've had some exposure to it. And we'll find out that that will happen when we talk about cardiac muscle and smooth muscle to some extent. So don't sweat the details, sit back, relax, watch this video, follow along. Don't worry too much about the details or wrapping your mind around everything that I'm talking about, okay? I just want you exposed to it. Don't study it, for heaven's sake. Don't, spend an hour studying everything I talk about in this video, because if you are, then you're not focusing upon the things that I wanted you to focus on. I want you to focus on the stuff that I put into the slide in the very first lesson in this series, at the very beginning of it, okay? All right. Inotropic drugs, all right? So you're going to run into these, and I think having a general idea of how they work and why they work is a good idea, and how they integrate into the details of the physiology is important. It also is meant to sort of demonstrate to you why the details are important and how everything interacts from the subcellular level and the level of the proteins all the way up to effects that you can actually see in an individual, okay? And I want you to start making those connections and putting them together instead of compartmentalizing things like the biochemistry away from the pathophysiology, okay? That's not a good idea. You should be trying to integrate it as much as you can. Okay, and if you do, then it'll all fall together better, and there's a much better chance that you'll actually remember it. All right, inotropic drugs. So, some typical examples: we have the cardiac glycosides like digitalis, which I'm sure many of you have heard of, digoxin, digitoxin, wabane. These are all sodium potassium ATPase inhibitors. Okay, they inhibit the sodium potassium ATPase, which you see here. And you might think, well, isn't the whole idea to increase calcium in the cytosol and increase force of contraction? How is inhibiting this going to do that? Well, what happens is you're pumping less sodium out of the cell, which means that you've got more sodium left behind in the cytosol. Okay? And another way of saying that is you've decreased the gradient for sodium from outside to inside, okay? Sodium high on the outside, low on the inside. Well, if you inhibit the sodium potassium ATPase, all of a sudden sodium's not so low. It's still low, it's way below what you find outside, but it's risen, and so the gradient has decreased. Well, what does that mean? Well, now we look at our sodium calcium exchanger, which I told you in an earlier video operates because sodium flows down from high concentration to low concentration. And as that happens, this protein works in such a way that you are forced to move calcium out of the cell from low concentration to high concentration when that happens. Well, if this, it depends on sodium moving from high concentration to low concentration. Now, all of a sudden, the intracellular concentration not so low. So this gradient isn't as big, and so now we're not moving as much calcium out. And if you're not moving that calcium out during diastole, then it's left behind, okay? And so you have less cytosolic calcium removal during diastole, and that, and therefore you have more calcium, and that calcium is actually taken up into the SR by the SR calcium ATPase. Okay? If it's left behind by the sodium calcium exchanger, it's going to be sucked up by this pump. So you get more calcium accumulation in the SR, and that gives you more SR calcium release, which means that you have more cytosolic calcium during systole, which means you have more force of contraction. Okay? And that's how this drug works. It starts here, and really here, and the effect that the decreased sodium gradient has during diastole, but because you're leaving calcium behind, it gets sucked up into the SR. Because it's in the SR, on the next beat, you release more calcium. And if you release more calcium, you get more contraction. If you get more contraction, you get more stroke volume. You get more stroke volume, you get more cardiac output. You get more cardiac output, your blood pressure goes up, which, as you will find out, is usually the purpose behind increasing force of contraction. All right? Sympathomimetics, norepinephrine, epinephrine, dopamine, dobutamine, isoproterenol, all stimulate beta-1 receptors. So we introduced this in the last video. Here's our sympathetic nervous system on this side. Here are our beta receptors. And what these drugs do is they bind the beta receptors instead of norepinephrine or epinephrine. Well, unless you've given them epinephrine or norepinephrine, in which case that's what binds. But if it's dopamine or dobutamine, isoproterenol, they're binding these receptors instead of norepinephrine, and they're having the same effects that activation of beta receptors will have. And these are some of the effects of these drugs in the system. So, and here you'll see, here's your beta 1 adrenergic effect, increased contractility, increased force of contraction in cardiac muscle. All these have that effect through these beta receptors. Now you will also notice that norepinephrine and epinephrine, they cause a vasoconstriction in vascular smooth muscle, which we'll talk about later. So this would be a side effect. If your whole purpose is increasing the force of contraction here, you have to be aware that some of these drugs are also going to bind alpha receptors, which are also part of the sympathetic nervous system. And so they're going to cause vasoconstriction, which may or may not be something that you want. So it's something that you have to be aware of when you give these drugs. They'll have side effects because they'll bind receptors other than beta receptors. Having said that, look at isoproterenol. It really doesn't bind alpha receptors. So it's really activating your beta receptor, and it's going to give you a pure contractile response with very little effect on vascular smooth muscle, maybe a little vasodilation, which we'll talk about at a later date. Okay? So be aware of the fact that there is more than just beta receptors as part of the sympathetic nervous system, and it's binding of these things to things other than beta receptors that will cause a side effect, and that is very typical. Okay? We have phosphodiesterase inhibitors, which also act on this system. So if I inhibit phosphodiesterase, that means I'm not breaking down as much cyclic AMP. So I'll have more cyclic AMP, more activation of pKa, which means more activation of all these targets in the cell, okay? Which means you'll have what is effectively mimicking a sympathetic response, okay? Amrinone, milrinone, those are typical, okay? And I am not into, for the sake of physiology, having you memorize drug names, unless it's really obvious and it's one we've used a lot. You shouldn't have to worry about it, and you definitely don't have to worry about it as far as I'm concerned right now. I'm just giving you these, don't memorize them. Don't memorize any of this, all right? Not yet. Phosphodiesterase knocks that down. Okay, so generally speaking, inotropic drugs give you higher myoplasmic calcium levels during the action potential, meaning during systole, due to more calcium entering from the extracellular fluid or more calcium released from the SR, most commonly both, okay? The higher myoplasmic calcium increases the force of contraction because it acts on the myofilaments, and as you will find out, it binds to troponin C and activates them, and that causes the force. More calcium, more force, and I did want you to remember that. More forceful contraction of the heart leads to an increase in stroke volume. Cardiac output is equal to heart rate times stroke volume. More stroke volume means more cardiac output. I did want you to remember that, okay? And there it is right there. Increased cardiac output will increase arterial blood pressure. You will find that out in the next lesson that I give you. And that is a major deal in terms of the cardiovascular system. Your cardiovascular system is tuned to regulate this physiologically and keep it as constant as possible. When you're giving a positive inotropic drug, you are most likely trying to keep that arterial pressure high, closer to a normal level, as close as you can get. Increased cardiac output and blood pressure produce greater perfusion of the tissues of the body, okay? So, by taking you through this, I hope I've accomplished at least one thing, and that's showing you how actions on the protein level, the subcellular level, lead to effects on the gross level and effects that you can see in a real patient. In other words, they're really medically relevant, and understanding how changes on the protein level result in changes in a patient you can see is really the essence mechanistically of medicine, okay? And it's something that you probably really should be trying to do as much as you can all the time. There are going to be points where you're just going to have to remember some things, and you're not going to have time to think mechanistically through every step. But at bare minimum, by the time you're done with this block, I hope that you'll be set up to be able to do that in any situation where the information is available. You'll have the understanding under your belt of how it all works, to where you can put the pieces together and go from submicroscopic to effect that you can see in a patient, and go from effect that you can see in a patient to the submicroscopic level where you've got an effect on a protein, all right? And going up and down that ladder really is the essence of mechanistic medicine, all right? And it's really something that we'd like you to be able to do as much as possible. Understanding, you know, how changes in the sodium gradient can give you changes in secondary active transport, which can result in changes in a cardiac cell, which may be something desirable, is really something we want you to kind of get, okay? And how changes in the sodium gradient can give you side effects is something that we'd kind of like you to be able to eventually get as well, because this is very common. Some pathomimetics, phosphodiesterase inhibitors increase heart rate and therefore cardiac output and therefore blood pressure and therefore perfusion of tissues, which can lead to a noticeable improvement in your patient. We're going from low subcellular level to high level. What can I see in a patient when I look at it? And ultimately, that's why we teach you this junk, okay? We're not trying to waste your time. We're not trying to provide, generally, we're not trying to provide hoops that you just have to jump through, which are going to mean nothing to you as a doctor. If you talk to upperclassmen in clinical rotations, they will tell you to pay attention to many of these levels, and they will tell you particularly to pay attention to the physiology, because it is something that you're actually going to have to apply in your rotations, okay? Because it's the heart of how much of this works. It's the heart of the pharmacology. It's the heart of the pathophysiology, obviously. You know, it's the heart of many of the aspects of medicine that you're going to have to apply in the near future, closer than you might think, all right? So having said all that, that's my spiel. Thank you for your attention. That's the end of this lesson, and now you can finally move on to a lesson where which I'll expect you to treat like a normal lesson where you actually have to kind of learn the material, all the material. Thank you for your time.